Okay, let's unpack this. I want you to, just for a second, close your eyes and picture a nurse.
Hmm.
What's that image that immediately pops into your head? It's probably very specific, right?
Oh, yeah.
You're seeing scrubs. You're seeing a stethoscope. You're seeing someone, right at the bedside.
Holding a patient's hand at 3 in the morning.
Exactly, checking a beeping monitor. It's a very visceral, very tactical image.
It is. And look, it's an accurate image, but only to a point. That is the absolute heart of clinical care.
Right.
But if that's the only image you have, you are missing about half the movie.
Yes, and that is what we are blowing up today. We are stepping away from the bedside.
And walking straight into the boardroom.
Straight into the boardroom. Our mission for this deep dive is to unpack the transformation of the nurse executive. And we are not just guessing. We have this huge stack of source material.
A massive stack.
Comprehensive student portfolios, reflections, data analyses, all labeled EPLO 1 through 6. This is all from a master's level nursing leadership program.
And just to set the stage, EPLO stands for Expected Program Learning Outcomes. These documents, they're basically a map of a brain transplant.
A brain transplant. I like that.
Yeah, we're watching a clinician, someone trained in physiology and empathy, evolve into a systems thinker who has to deal with finance, policy, global strategy, everything.
And that map has some wild twists.
Yeah.
That was the hook for me. The contrast is just, it's jarring.
In a good way.
In the best way. One minute I'm reading a reflection about helping a breast cancer survivor with body image issues. Super intimate, super personal. And then you flip the page and they're running a SWOT analysis on $1 million robotic surgery unit.
And that's the reality of modern healthcare leadership. It's not just about learning, boss skills. The sources show they're integrating 6 very specific outcomes.
Right.
From evidence-based practice to health policy, global health, informatics. They have to become bilingual. They speak patient care, but they're learning to speak business strategy.
So let's dive right into that business strategy part, because that is where I had my first big aha moment. It's in the data for EPLO 1 and 2. There's this incredibly honest confession from a student. They said, and I'm quoting here, "I was unaware of what any sort of budgeting entails."
And that's a very common starting point. I mean, most nurses are trained to think in terms of blood pressure and heart rates, not fiscal quarters.
Of course.
But then you see where they end up. In that same data set, you have a student creating a full SWOT matrix, strengths, weaknesses, opportunities, threats, to justify increasing outpatient exam rooms.
Yeah.
And what I loved is they weren't just saying, hey, it's crowded, we need more space.
Wow.
They were analyzing how to optimize space to mitigate main campus census overflow. I mean, and that is pure corporate speak.
It is. And it means we are losing money because we can't move patients through the system fast enough.
Right.
So the bedside nurse sees a crowded waiting room and feels stress. The nurse executive sees an inefficiency in patient throughput that's threatening the hospital's market position. Speaking of financial risk and reward, we have to talk about the robots. This was an EPLO 4, the business plan for the Da Vinci robotic units.
Oh, this was fascinating.
It sounded like something from Wall Street. The student wasn't talking about how cool the robots are.
No.
They were projecting an 8% growth in case volume and profit. They were arguing that to maintain their status as a center of excellence, the hospital had to invest.
And that phrase, center of excellence, is so important here.
Why is that?
It's not just a vanity title, it's a branding strategy. It attracts top surgeons, which attracts patients with good insurance, which drives revenue. So what that student is doing is connecting a piece of high-tech hardware directly to the hospital's financial survival.
But I have to play devil's advocate here for a second, because I think a lot of listeners might feel this too. When we hear profit growth and branding,
Healthcare,
it makes you a little nervous. You worry that if the focus is on the budget, the care suffers. Is the nurse executive just becoming a suit?
It's a totally valid fear, and that tension between money and care is always there. But the portfolio actually gives us a great example in EPLO 5 that just flips that script.
The vital sign machine proposal.
Yes. The nurse administrator advocating for a new vital sign machine that automatically inputs data into the EHR, the electronic health record.
Okay.
Now, on the surface, that sounds like a convenience request. Hey, buy us this fancy gadget so we don't have to type numbers in.
And the CFO would laugh you out of the room.
Exactly, because those machines are expensive.
Yeah.
But the student didn't pitch convenience. They pitched safety.
Right.
They used hard data on nursing errors from manual input. They showed that a human being making a typo when entering blood pressure was a real safety risk. They basically monetized error reduction.
So they used the budget. to buy safety.
And that is the whole crux of the business of caring. They prove that financial savvy isn't the enemy of patient care. It's a tool to protect it. It's that simple.
You know, that's a perfect transition. We've talked about spreadsheets and robots, so let's get back to the human element. The sources mention this concept of the leader within in the EPLO2 data.
The leader within, it's that internal shift. Realizing leadership isn't just about a title. It's about your own values and how you influence the culture around you.
And nothing screams culture right now more than burnout. I saw a research poster in the data about mental health days for ICU nurses.
Right. And notice the rigor they used. The student didn't just say, "We're tired, give us a day off." They used the PICOT method.
Okay, hold on. You have to explain PICOT for us because that popped up a few times.
Sure. It stands for Population, Intervention, Comparison, Outcome, and Time. It's a framework for structuring clinical research questions.
So it turns a complaint into an experiment.
Precisely. Instead of just a feeling, the student asks. In ICU nurses population, does implementing mental health days intervention compared to standard scheduling comparison actually reduce burnout scores, outcome, over 6 months' time?
You're treating staff well-being like a clinical outcome to be measured, just like you'd measure infection rates.
Exactly. And
Okay.
that is how you get administration to listen. You bring them data, not just emotion.
Although, sometimes the emotion is the data. I was really moved by that proposal in EPLO2 about body image of breast cancer patients.
That was a really powerful example of that leader within.
Yeah. The student reflected on how they used to talk to patients,
Right.
and they realized they were hiding behind all this medical jargon, incisions, drainage, medications.
The clinical benchmarks.
Right. And so they completely reconstructed their post-op education to be less about the medical side and more about how the patient feels. Specifically, how they feel in the eyes of their partner.
It shows this profound level of empathy, but again, it was backed by structured inquiry. It wasn't just a nice thought.
And speaking of structure, we have to mention the process here. There's this document in the sources called an IRB termination report form.
Ah, yes, the paperwork.
It looked intense. It's talking about adverse events and subject enrollment breakdowns. It looks like a legal document.
In a way, it is. IRB is the Institutional Review Board. They are the gatekeepers for all ethical research.
So these nurses aren't just brainstorming on a napkin.
Not at all. They're navigating these really complex, bureaucratic, and ethical frameworks to do legitimate scholarly inquiry. It elevates their work from just good ideas to scientific evidence.
So they've got the money handled, they have the research handled. Let's talk about changing the rules, policy and advocacy. I have to share my favorite story from EPLO3, the Go Clear initiative.
The surgical smoke issue, a classic example of an invisible harm.
I had honestly never thought about this.
Yeah.
When tissue is burned in surgery, it creates this smoke, this plume.
And it's toxic for everyone in the room.
But the student didn't just write a paper about it.
No. They spearheaded an actual campaign.
They applied for the ARN Go Clear Award. They fought against physician resistance. I mean, can you imagine that? You're a nurse telling a surgeon, hey, the air in here is toxic, and we're changing how you do your job.
That is the absolute essence of advocacy. It's almost never popular at first. It takes data and it takes a spine.
That's where the executive part really kicks in. It's not asking permission, it's setting a new standard.
Yeah.
And you see that same advocacy at work for vulnerable populations.
Like the plan of safe care that was mentioned in the sources.
Exactly. This was in EPLO 3 and 5. It focused on pregnant patients with substance use disorders. The easy thing to do would be to just deliver the baby and discharge them.
The treat and street method. Address the acute problem and move on.
But the leader makes sure there's a coordinated plan with social work and pediatrics so that when that mother and baby leave, they have a safe place to go.
It's seeing the patient as a whole person. And sometimes that advocacy is surprisingly small, but so effective. I loved the Vaccine Safety Project.
This one blew my mind because it was so simple. The problem was medication safety events with vaccines.
And the solution.
Printing CDC labels on waterproof paper for the refrigerators.
It sounds so trivial.
But it reduced safety events by 20%. Just because the labels didn't get soggy and unreadable, that is a nurse executive mind at work.
That's systems thinking in a nutshell. A novice nurse just tries harder to read the soggy label. A nurse executive asks, why is the label soggy in the first place, and fixes the system.
And that competence goes way beyond the local hospital. In EPL4, we see them widening the lens to a global scale.
The contrast in the student work was really stark there.
Yeah. One student was comparing polio in India using these sustainability models to eradicate a virus with maternal mortality in Uganda.
And that comparison seemed to have a really deep emotional impact.
It did. There's a quote from the student saying, "I felt such a level of sadness that women are dying in Uganda. I have considered doing a medical mission." It's like the data woke them up.
But what's so fascinating is how they bring that global awareness back home. You don't have to go to Uganda to find diversity. EPLO5 gives us that great example of local cultural competence, the kosher kitchen.
Oh, right. The facility that transitioned its entire kitchen.
Think about the logistics of that. It's not just buying different food. It's separate prep areas, new suppliers, strict oversight. It's a huge operational lift.
So why do it?
Because they saw that their resident population was predominantly kosher. So by changing the food, they weren't just feeding people, they were creating a home-like environment. They were signaling respect for identity.
It connects back to that age-friendly systems framework, right? The 4 MIMS.
Yes, what matters? Mentation, medication, and mobility.
What matters? I love that as a clinical metric. It shifts the question from what is wrong with you to what matters to you.
Exactly. Whether that's religious dietary laws or being able to walk to the bathroom on your own, it's all connected.
So we've covered the human connection, global, financial. Now we have to talk about the digital connection, technology.
EPLO6. This is where the future arrives.
And apparently, the future arrives on an iPad.
Doesn't it always?
There was that great detail about using iPads for birth certificates.
It's a perfect example of efficiency-reducing error.
So normally, a registrar has to manually interview exhausted new parents to get all the info for the birth certificate.
And in manual data entry is where so many clerical errors happen in healthcare. Misspelled names, wrong dates.
Right. But in this project, the system pulls the data directly from my chart. It just eliminates the middleman.
It's faster, it's cleaner, and it frees up staff to do actual patient care. But the tech section wasn't just about efficiency. I was glad they included the Annie app for veterans.
Yes, the text messaging system. But the example that really stuck with me, I think it'll stick with our listeners, was the reflection on weight loss during COVID-19.
Oh, that was heartbreaking.
We all remember the isolation, but this student focused on a specific clinical result of that. Patients were refusing to eat because they were lonely. They were just giving up.
So the problem wasn't biological, it was emotional.
Exactly. And the solution wasn't a new drug or a feeding tube. It was using video conferences during meals. They set up tablets so families could provide verbal encouragement when they couldn't physically be there.
Telecomfort.
And it worked. The patient started eating again. It shows how tech can be a bridge. It closes the emotional gap when the physical gap is impassable.
And that, I think, really brings us back to the synthesis of all this material. When you step back and look at these 6 EPLOs, finance, leadership, policy, global health, diversity, tech, the picture of the nurse executive gets really clear.
It's a hybrid role. That's my takeaway. They are part financial analyst, calculating the ROI on robots. They're part policy advocate, fighting for smoke-free rooms, part tech implementer, rolling out iPads, and they are still, at their core, that emotional support system.
They're the translators. They translate the needs of the patient into the language of the system.
Right.
Without them, the business side gets too cold, and the clinical side gets too chaotic. They hold the center.
It really makes you rethink who is actually running the show in a hospital.
Well, and that raises a pretty provocative question to leave our listeners with. We saw in the EPLO6 analysis that these nurses are mastering competitive strategy, high-level finance, market analysis.
Skills usually reserved for the C-suite, for CEOs.
Exactly. So what does that mean for the hierarchy? The traditional hospital pyramid might be on the verge of being completely upended.
How so?
If the nurse knows the budget better than the CFO and knows patient care better than the chief medical officer, how long until they are the one running the entire organization?
From the bedside to the big chair.
It feels like the natural evolution. The data suggests they're already doing the job. They just haven't gotten the title yet.
That is a fascinating thought. Next time you see a nurse, maybe don't just ask for a blanket. Ask them for their 5-year plan for market growth.
They probably have one.
They probably do. Well, on that note, we want to thank you for joining us on this deep dive into the hidden complexities of nursing leadership. Hopefully, it's changed how you see the profession.
Absolutely.
Thanks for listening, everyone.